3, 2, 1, go. But Instagram's not live yet.
We're live?
On everything except Instagram. You're not there yet. Oh, and you're there. Go live.
We're good?
Very good.
Beautiful day. Welcome to Fertility Fact or Fiction. I am your host, Dr. Rahi Victory, double board certified reproductive endocrinology and fertility specialist, and off camera tonight for the first time in
Seems
ages.
like ages.
Right? How long?
Ages.
Like a year and a half?
Too long.
Is Tarek Ibrahim, the recent victim of crime where they broke into his car and stole all of our electronics and camera equipment. So we're still putting the show back together, unfortunately, but we should be back together by next week, hopefully.
I would hope so. Yep, absolutely.
We just have one piece missing.
One piece, just my piece, just a little switcher.
Yeah, just a switcher. So huge love for Tarek, who lost everything and now has to rebuild from scratch. Sorry, buddy. I feel for you.
It's a tough one.
Yeah. Also, a massive shout out to my son Mateen, who turned 29 today.
Oh wow, big boy!
If you're single and very good-natured and very patient, very patient, and very beautiful and very smart, then I got a catch for you. He's a hyper intelligent, tall, medium-colored, very muscular, extraordinarily intelligent lawyer in New York who does very well. And I want to wish him a very happy birthday and tell him how proud I am of all the work that he does and how rapidly he's risen in the ranks of one of the top law firms in the world and all the amazing things he's done, including saving literally hundreds of thousands of people's jobs. So Matt, we love you. We're proud of you, and your present is being shipped. So it should arrive shortly, but it's sizable. So
that's exciting.
It is exciting.
That's exciting.
Yeah. His mom and I had to put some serious thought into what to get the kid. He has everything. So it's like,
it's tough.
It's tough. Yeah. So happy birthday, Matt. We love you. And on behalf of Clan Victory, many more happy years to come, we hope. So tonight there's no study because I was away in Brussels at a fertility meeting where we were helping loads of men who want to have babies. So if you are straight, single, couple, gay, it doesn't matter. If you need help with an egg donor or a surrogate, please let us know. We have tons of families that need assistance and they need to build their families either through egg donation or surrogacy. And so we're at a meeting there where we're helping many different couples. And they all want to come to Canada because we are ethical, we are altruistic, we are much cheaper, and we provide top quality care and one-on-one nursing, which most other clinics cannot manage. So we were very thrilled to be kind of center stage in that process and at that meeting, and excited about what the future holds as well. So that's where things are at right now. Yeah, that's where everything's at for us. So with no further ado, I think we are going to take fertility questions. We did have some content that was supposed to come out, but unfortunately that went the way of the dodo, including that I have to separate more M&Ms, man. Do you know how long that took?
Yeah, I was there.
Yeah.
I was there. I was part of that separation process.
And I still got to separate a whole, we need more.
Because you,
well, I've ate half.
Well, first of all, you thought it was done with. You started to lavish in M&M heaven. I was shocked that they were still there. I'm like, there's no way you didn't eat them yet.
Like 2 or 3.
Good for you.
Rationing.
Good for you. Yeah. When they were here, after we did the video,
yeah.
I couldn't contain myself. And every couple seconds, I'm like, man, this has got to be the most dangerous thing in the world just to keep out there.
Yeah, no, I put them all in my office, and most of them I haven't touched. I picked at the yellow ones.
But it's strange how they're not equal color distribution.
No, that was weird.
Weird, right?
Yeah.
What was the least color? Red?
Red by far the least.
Right? Least amount of red.
Super low in red. Lots of brown, lots of blue, orange.
Blue was the winner, I think, right?
Green.
Most blues.
Probably.
Right?
Or green. There was
a lot of greens. There were a lot of greens.
Green and blue, there's a lot.
There was a lot.
Yeah. Red, they're anti-red in the M&Ms. So, fire away.
All right, ladies and gentlemen, welcome.
Oh, and for those of you, I should say this very quickly.
Yes.
For those of you who have not yet participated in the sheer fun of reading my vitamin K post with Tom Hardy on the front, please go read the insane, unhinged, deranged comments from people, including this new individual who is selling placental encapsulation, Reiki, all sorts of mumbo jumbo, and claims she was previously a labor and delivery nurse, and then now she has a connection with God, and is doing God's work by telling people to have a physiologic birth and not take vitamin K because the babies don't need vitamin K. And when asked for evidence over and over and over again, she has continuously failed to provide it. Finally, today, summarizing this with, I don't need evidence because I have my experience. And I was like, what? Like, where do these people come from?
I actually thought you were going to say God told me.
Well, I told her that. Actually, I said, listen, if you're hearing voices,
Yeah.
maybe it's time for some medication.
Absolutely.
So yeah, you got to read. It's pure, like, it's actually entertainment now. It's actually kind of fun. So go read those, and please feel free to comment. We would love that. All right, fire away.
All right, ladies and gentlemen, let us begin with our good friends on Instagram today. What's your POV, point of view?
Thank you.
No problem. On getting the COVID and flu shots while on suppression?
So I'm not a big proponent of COVID shots. If you're in a high risk category, sure. Otherwise, I'm not really sure why anyone's getting a COVID shot. But if you're at high risk, sure, I get it. Flu shot, if you mean like hormonal suppression, like your Lupron and letrozole, it won't make a difference. You can take any shot you want. But if you mean immune suppression, don't be getting vaccinated while you're immune suppressed. You're actually killing the ability to mount a response to the vaccine. So it's not going to work.
At 38 weeks with twins, is a C-section required, or can vaginal birth still be an option?
That very much depends on which direction the first baby is headed in. So if your first baby, meaning the lowest baby, is head down, you can have a vaginal delivery. If the first baby is not head down, you cannot have a vaginal delivery because the heads can lock. So if the first baby's butt is down, then the second baby's chin can lock on the first one, and you end up with this, and that's not good at all. It would be really bad. So what we end up doing for those babies is cesarean sections when the first baby is bum or foot or whatever down. But if the first baby is head down, you can have a cesarean section. The only thing you need to remember, which is important, is, and this is critical, that you need a physician who is capable of delivering a breech second twin. Now, while I would argue that every OB should easily be capable of delivering a breech second twin, not every OB can. And you have to remember that in some instances, delivering that baby means you actually reach all the way in, like up to your elbow, find the baby's feet with your hand. You got to grab the feet sort of like this or like that through the membrane, grab onto them, pull them down, break the water, and then do a breech extraction. So am I comfortable doing that? Absolutely. I've done it literally hundreds of times. Is everybody comfortable doing that? No.
I'm not, for sure.
Yeah.
That is way beyond my pay grade.
No, he would not be. So
yeah.
If you're comfortable with it, great. If you're not comfortable with it, let us know. Also, if you're watching on TikTok, can you please let us know what you think of the sound? Because we are using a new mic system, and I want to know what you guys think of that.
Dr. V and Monarch T, how often do you use dexamethasone for an egg retrieval in endo patients?
We haven't been, but I think we will. So I'm not quite there yet. I've been overwhelming my new nurse manager, so I didn't want to throw yet more stuff at her, but we will likely start doing that soon once things have settled down a little bit.
Sound is good.
Sound is good.
It's always good when sound is good.
That's good.
It's a huge relief.
Yeah.
Hey, Dr. V&T, I watched the endometriosis protocol video you have.
Okay.
This is an old, they're going back here.
Yeah.
And I wonder,
Yeah.
is letrozole very much needed in addition to Depolupron? And what do you think of Orilissa?
Well, Depolupron by itself has been proven to be useless. So by itself, it doesn't make any sense. It's only when you combine it with letrozole that there are actually studies that show benefit. So that's number one. With regards to the Orilissa question, there is absolutely no evidence that Orilissa is beneficial prior to FET for endo patients. More importantly, the pharmacology of Orilissa basically suggests that it keeps the estrogen in the mid-follicular range the whole time, which is like not high estrogen, but it's not low either. So that shouldn't suppress endo all that well. And so it doesn't make sense to use for an endo protocol. That's not to say Orilissa isn't a great drug. In many instances, it can be very helpful, but not for this purpose because it doesn't make sense. We're trying to turn off your estrogen to suppress the endo. Using Orilissa is not going to turn it off. It's like a dimmer switch turned down to like a 3 out of 10, or maybe a 2.5 out of 10 or something, 2.7. So it's not a complete turn off. And what we want is like a -5.
Switching gears to YouTube.
Okay.
Hello, handsome doctors.
Oh, wow. There you go. That says something for you, buddy, because you're off camera.
And I'm still projecting. They can still tell.
Do you want to jump on camera?
No. Let their imagination run wild. Let it run wild.
Yeah.
What are your thoughts on using methylprogesterone starting stim day 1 instead of the antagonist Generilex as ovulation blocker?
Did you mean medroxyprogesterone instead of methylprogesterone?
No. Well, maybe that's what they meant, but it says methylprogesterone.
Okay, there is no methyl or methyl. There's medroxyprogesterone. So there are many studies looking at something called PPOS, which is progesterone primed ovarian stimulation, where you start your stimulation and you take progesterone at the same time. And virtually every single study available shows that essentially there's no difference in outcomes. Now, I haven't jumped into it because I'm still waiting for a bigger study to come out, but or a randomized controlled trial where they compared it. And I haven't seen a really good one done yet, but we might switch to that in the future, mainly because it's so much cheaper. So that's another opportunity to save some money for patients that want to.
I don't know what's going on, but the camera, you look so good. Honestly, it's just so great. Like if people are even asking, is there a new camera? I'm like, well, it's technically new, but it's not technically new. But
it might be the new laptop.
Maybe. But you're looking.
Well, remember, it does go through the
Mac.
No. When we were doing it before, it went through the switcher. Maybe
the switcher sucks?
I don't know. Maybe it degrades the video quality. Who knows?
Oh, yeah.
You might need a better switcher.
I bought a better switcher.
I had no doubt.
I bought a better switcher. Hence, my wife thinks it's Christmas. Hi, Emperors.
Oh, we got upgraded.
We are moving on up.
We're gonna be running out of things soon.
No. They are a creative bunch, these guys.
Yeah.
I had stage 4 endo surgery years ago.
Okay.
And now have no symptoms, a small endometrioma, and some adeno.
Okay.
After 9 IVF cycles, I have 1 euploid, she continues.
Whoa.
My doctor recommends suppression only before transfer and not more surgery. Would my chances be lower with suppression alone? Continued again.
Yes. Let me answer that before I lose track.
Okay. You want to jump in here so far?
No. I
Okay.
mean, yes, your chances will be lower if you have an endometrioma and you don't remove it.
Followed up with, is there a certain level of endo-adeno where surgery plus suppression improves transfer success compared to suppression alone?
That study has not been done, so I can't answer that. But what I can tell you is the studies are clear that surgery improves your success rates. And there's also no question that the suppression improves. So the combination should, in theory, be better. Now, is there direct evidence for that? No. But we know that it's going to be better. And there's not stage by stage. But there is evidence that endosurgery can improve the outcomes prior to doing your embryo transfer. Again, surgical studies are very hard to do because like what one person's surgery is like is not the same as another person. So it's not an easy thing to achieve. However, I will say this. I saw a study today posted by a NAPRO kind of star on Instagram, Naomi Whitaker, who I chat with frequently, and she's lovely. We actually are supposed to have her on the show too, so you got to reach out to her. So these are people that don't really believe that much in IVF. They're more into let's naturally help the procreative process, hence the whole NAPRO. So they just came out with a study looking at a large number of patients that were followed, and their pregnancy success rate was really high. And these are people that did not do IVF. The majority of them underwent either laparoscopy or hysteroscopy and still had fantastic results. So make sure you're checking, all your options, because you don't always need IVF. I say that all the time. And more importantly, there is more and more evidence coming out that IVF is not always the solution. We have a video clip where someone had been told that IVF was the answer to endometriosis. IVF is not the answer to endometriosis. And I ranted about this before, but I'll do it again. IVF makes endometriosis worse. Like that's been shown. We know that IVF worsens your endometriosis. We know that IVF is going to drive up your estrogen levels. We know that it's going to make the pain potentially worse. And it's also going to stimulate things like endometriomas. All of this is a known quantity. There's actually research on this to show that this is true. Deep infiltrating endometriosis, worse. Endometriomas, worse. So does it make any sense for people to say that IVF is a treatment for endo? No, IVF is like, taking endo and force feeding it rocket fuel. It doesn't make any sense. So make sure you're getting the right answers from a doctor that cares, not about forcing you into IVF, but actually cares about helping you get pregnant. Not everybody out there is like that.
I actually think this thing here is getting the video to look so good on you.
You're still stuck up.
You have no idea how great you look.
It could also be the resolution of your new screen.
There's a lot of factors at play here. But I'm thinking that this thing's 4K. It says 4K, and the other one is just HDMI. Like I never thought that there's a thing there.
Well, HDMI can still pass 4K.
Can it?
Yeah.
Well, that's the question now. Can it?
Yeah, of course.
I would assume, but the way you're looking, it did not pass. It did not pass.
All right. Well, now we've got a whole video upgrade. So
that's right.
This setup has to stay no matter what.
No matter what. Well, now I have to really review what I just.
One of those that does a double input.
Well, that's what I got to figure out. Now it's really concerning because now I have to figure out that the one I buy, is it also 4K or not? I just bought the newer version. I don't know if it's. Yeah. No, I don't know. Hey, Dr. V and social media, Dr. T. Oh, a lot of good titles in that. When do I stop ALA, NAC, resveratrol, CoQ10, and L-arginine for FET? I'm ending my 2-month suppression after removal of stage 4 endo.
When you deliver your baby, that's when you do it.
Straightforward answer.
What's going on TikTok?
TikTok. Here we come, guys. Kept you waiting because you didn't give enough likes, but we're here now. Okay, one of two, Dr. V. You ready?
Sure.
Dr. V.
Yeah.
I almost got to meet you this morning.
Oh.
You walked in behind me to the clinic, but went in a different way.
Yeah.
I was all prepared to hold the door open for you and say hello.
I know who that is. So thank you. And I'm sorry I missed you, but I was 3 minutes late for my appointment. So I was trying to race directly into my office. It's a sneaky door that I can get into and out of without people noticing. So thank you for offering to hold the door. Yes. And also huge thanks to Heather, who made us brownies and UPS them to us. And you talk about love and dedication.
Heather is a winner. Absolute winner.
We love Heather. Yeah.
28 weeks.
Yeah.
Stillbirth.
Oh.
Emergency C-section birth. How long before we can start TTC given infertility?
Well, you shouldn't get pregnant for a minimum of about 6 months, just to let the uterus heal. But after that, you can, as long as you're willing to have another cesarean section. If you do not want another cesarean section, it's 15 months from delivery to pregnancy, or 24 months delivery to delivery.
Dr. V.
Yeah.
Do you offer selective reduction?
Sort of. I don't do it myself. We send you to the University of Toronto, where there are, to the best of my knowledge, currently 2 doctors that offer that service, and they're the ones that take care of it for you. Garth Seward and Wendy Whittle.
How soon after an egg retrieval are you likely to get your period?
2 weeks, exactly.
After egg collection, is it normal to have pain in the ovaries after 2 weeks?
It can be. I mean, it depends on how many eggs they got and what was involved, and what they did, and whether or not you needed flushing, and a whole bunch of things. But I would recommend that everybody take that seriously, because if you had pain at the time of your egg retrieval, you likely or flushing or something like that, and you're now still having pain, the potential for a complication, bleeding, infection, that kind of thing is there, and therefore you don't want to ignore that. That's something serious.
What day is the earliest to be able to test at home following an FET?
At home, realistically, I'd say like day 9 with an early test kit, and not panicking if it's negative. But we highly recommend against doing that. It just makes you go crazy for a few days and is not always valid. So don't test early, please. I beg you, don't.
Woosah.
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 You remember that?
Yeah.
It's such a good movie.
Woosah. I've had 3 first try miscarriages.
Oh.
Done RPL testing, euploid embryos. What else can we do?
Microbiome, immune testing, thrombophilia screen, karyotype for both of you, your vitamin and thyroid levels, your partner's sperm DNA fragmentation, arguably in that circumstance, whole genome sequencing for any aneuploid embryos you still have left, 3D saline fusion sonic histogram to look at the shape of your uterus. There's a lot of things you can do. A lot. Like, there are many.
And I feel that people don't know that there's many things that can be done. And I think it's underplayed, the microbiome testing.
Well, a lot of people are actually getting testing on, like when they say they have a recurrent pregnancy loss test. So they get like a karyotype, and then they get maybe a sperm DNA fragmentation, and they'll get a thrombophilia screen. That's it. They're done. That's not a recurrent pregnancy loss test. A recurrent pregnancy loss test is looking at everything. So on the male side, what's your DNA fragmentation look like? What's your oxidative reductive stress look like? Do you have an increase in aneuploid sperm, which can also be tested? What's your maturity level like? Did they do a hyaluronic acid binding assay? So there's many things we can do on the guy side, plus the holy grail of does he smoke, drink, and use drugs, because all of that stuff can drastically impact your miscarriage rates as well. On the female side, hormonally, what are your hormones doing? What's your thyroid doing? Do you have thyroid antibodies or not? If that's not looked at, you're not getting a recurrent pregnancy loss test. What's your glucose control like? What are your sugar levels like? Insulin resistance, those sorts of things can have an impact as well. What are your vitamin levels like? That can also have an impact, especially vitamin D, which has been shown closely to be related to miscarriage risk. And then you've got to look at the anatomical things. What is the shape of the uterus? Do you have a narrow uterus? Do you have a T-shaped uterus? Do you have a Y-shaped uterus? Do you have a uterine septum? Are there fibroids? Are there polyps? All of these things are critical elements of any recurrent pregnancy loss workup that many people are not getting for reasons I can't understand, but they're just not getting it done. And then you need to look at the microbiome, and you need to look at the immunological system. If you're not getting all of that done, you are not getting a recurrent pregnancy loss workup. So it is very important to make sure you are seeing someone who actually knows what they're talking about, because when you go to the doctor and they say, we're going to do an RPL workup for you, and you get tossed a karyotype and a thrombophilia screen, that's like scratching the surface. And I'm going to tell you in advance, those are probably the two tests with the lowest yield for finding something wrong. It's almost never that we find that someone has a thrombophilia or a karyotype abnormality. How often do we find a microbiome or an immune problem? All the time. So if you're dealing with doctors that don't look into those sorts of things, you're not dealing with a great team of doctors. Keep that in mind.
3 months of suppression. Sorry to hear about your stolen things, Tarek.
Yeah.
Wow.
That's nice.
That's nice.
That's nice. We got to start a GoFundMe page for you.
Yeah, there we go.
We should start a GoFundMe.
We should start a GoFundMe for you.
How many people think we should start a GoFundMe page for Tarek? I would love to know the audience. Yeah.
Professor T.
Professor T. Very nice.
And Dr. V.
And Dr. V. Okay.
I'm not mad at that. It's not a king. It's not a lord. It's not no monarchy here.
Yeah.
But it's professor's not bad.
Not
Professor.
bad at all. Yeah.
Tubes open on HSG.
Okay.
No endometriomas.
Okay.
4 chemicals.
Okay.
Unexplained.
Okay.
Diagnosed with adeno.
Okay.
How likely is it to have endo with adeno? And should I get a lap before the FET to rule it out?
Well, it's not causing the chemicals necessarily, although it can. Bad adeno certainly can, especially if it's not being treated with an appropriate adeno-endo protocol. But you're probably somewhere between 30 to 50% likely to have concomitant or concurrent endometriosis when you have bad adeno. So I would use our endo-adeno protocol because it works.
Dr. V.
That's me.
Question from TikTok.
Yeah.
Best protocol for DOR with AFC of 14 to 20, 40 years old.
What?
Mm-hmm.
How can you have a DOR if you have an AFC of 14 to 20? That makes no sense.
Thought you'd like that one.
That's insane. You can't have DOR if you have an AFC of 14 to 20. If your antral follicle count is 14 to 20 at 40, you do not have DOR. You actually have remarkably strong ovaries. Now, it may be that your AMH is different and it's low and you have follicles that don't respond, which we do see from time to time, but there is definitely something wrong with whatever they told you, because that does not jive with what's regularly happening. What would your best protocol be? It would really depend on how responsive your ovaries actually are. We generally recommend a combination of a recombinant with FSH activity and then something with LH-like activity, Menopur or Luveris, they're both good. And then you need to stimulate for no more than 12 days maximum. Do not take high doses, proven to be detrimental. That's super important for people to understand. And then double trigger and see what you get. But it will very much depend on whether or not you need priming, because you are truly DOR, things like testosterone, DHEA, human growth hormone, or whether you do not need those because you actually have an AFC of 14 to 20. So that story doesn't make great sense. There's got to be more to it. And if they told you you had DOR and you had an AFC of 14 to 20, ask them why they told you you have DOR. On what basis? What's the evidence for that? How is that possible? How can you have an AFC of 14 to 20 at 40 years of age, which would be considered amazing, and then be told that you have DOR? That doesn't make sense. Something is amiss there. There are cases where we see it, and it's based on other information that we say you might have DOR, including and especially prior stims and how you did with that. But as a general rule, what you're describing there, it doesn't make any sense for what we'd expect from someone.
Dr. Victor in high definition. I'm telling you, man. It's not just me.
Okay, flip it over. Let me see.
Yeah.
I gotta look at myself here.
Can you see?
Yeah, that is very sharp.
Very sharp. And then this is just on Instagram. If I go to actual YouTube, my God, man.
It's even sharper.
It's even sharper.
And it's like more live. Instagram's got that delay. That's
yeah. Right?
Yeah, the YouTubers are seeing you 1 second.
The YouTubers are really enjoying you today.
Wow.
All
right.
This is all the Dr. V I need. This is great. This is amazing. This is like real life. I could touch you, man.
Tarek is, dude, I'm 1 meter away from you, and don't touch me or I'll kill you.
Feel like I can touch him.
Oh, it's Fertility After Dark. Yeah.
Fertility After Dark. Roll out the flashlights.
Yeah, exactly. So go ahead. Next question, please.
I'm trying. I was going to sip on my tea, but I was nervous. 42 years and 2 rounds with IVF with 6 eggs retrieved and 0 in the blast. How many more tries prior to giving up?
Those are the cases where you need to DM me and tell me what you did, and I can tell you. But use Fortune IVF. It's a free app you can download on any app store. Plug it into your phone, enter your information, and it'll tell you what your chances are. And the good news with it is it's very accurate when your chances are terrible. When your chances are 0, it'll actually tell you your chances are 0. So Fortune IVF, that's what everybody should be using. Like, save yourselves money and time. There's no reason to be spending a ton of money on this if it's not going to work.
I know you recommend double prog for endo patients. Is there a study on this? If so, where can I find it for my doc?
There is.
Hold on. Before you get into it, because I think this is important here. I would like to make a comment.
Okay, yeah.
Now, my comment is not going to be. It's actually going to be quite colorful.
Okay.
It's going to be quite a colorful comment.
All right.
But if you need a study to take to your doctor, to show your doctor that your doctor is doing it wrong, I think there's a whole other question that needs to be addressed.
You know what? You can say that. I'm not
That's
sure
why I said it.
I'm glad you said
Yeah,
it.
I said it.
Yeah.
I said it. I saved you that.
That was colorful. I like that. I'm not going to say that I don't disagree. So endo patients are known to be progesterone resistant. That's well established. Everybody that knows endo knows that. And so you need higher progesterone. We presented a study on fertility fact or fiction, which is on our YouTube video collection. I don't remember now what it's called, but I'm sure we can find it if we look. And that video reviews the study that showed you that you need a higher dose of progesterone. There are also other studies that have shown that a combination of vaginal and injectable is better than just the vaginal or the injectable alone. So that's a no-brainer. You just need to find the data. But if your doctor doesn't already know that, I'm going to agree with Tarek to some extent carefully and say, like, why don't they already know that? And do you want to be with a doctor that doesn't already know that? That doesn't make sense. If I'm going to the doctor, I want to be with the doctor. Okay, first of all, I'm terrible. I very rarely go to the doctor. But if I am going to the doctor, I want to go to the doctor with a ton of knowledge. So when I go for kidney stones, I go to Tom Deckley because he's local in our community here. And Tom is awesome, and he knows everything, and he studies, and he's an amazing surgeon. And he saved my kidney and ureter several times now from the hell of kidney stones. That's what you go to. You go to a true expert who knows what they're talking about, who reads, who lives it, who breathes it, who cares. So shout out to Tom. I love the guy. And he saved Tarek's kidneys too now. So that's what you do. What do you do when, you're with someone that doesn't do that? You go the other way. Like, take your embryos, take your money, and go somewhere where they know better. People are so afraid to leave their fertility clinic, right? Why are you afraid? You control the money, you control the narrative, your body, your choice. Huge advocate for that. Why are you worried about the fertility clinic? The fertility clinic needs to learn to ramp up to you. You don't need to go down to the level of the fertility clinic. They need to come up to your level, and quite frankly, my level. And so if you are not getting the care that you want, why are you there? Like that just doesn't make sense, especially when you're paying for it. You're paying for this care. You're paying a fortune for this care, not just financially. You're paying for it in tears, in emotion, in the cost and the trials and tribulations on your relationship status, on your sex life, on your intimacy, on how you feel about yourself, on your personhood, on your well-being, on every aspect of your life. It takes a massive toll. And then you're paying for someone to literally ruin that. I hate that. That gets me angry. Why would you do that? Don't do that. Go somewhere where they're going to care for you. I'm not even saying come to us, because we don't do that on this show. But go somewhere where they care for you. where they actually know what they're doing. There are some out there. There are not a ton out there, but there are some out there, and you can find them. I had a great post from my dear friend Sasha Hackman on Instagram the other day where she said, like all this work and all this effort. She was in the OR getting ready, and she goes, all this so that they can tell someone later on it was the McDonald's French fries that did it. And so I commented and I said, I know Sasha very well. It's 99% Sasha, 1% the French fries. Yeah. So go where you're going to be appreciated. There are some great fertility specialists out there. Sasha is definitely one of them. Although she's a scoundrel for not coming to work with me. But if you find someone out there who's good and who cares, go work with them. That's where you want your money to be, not with people that are just trying to tell you, do it again, just try again, oh, sorry, just try again. That's nonsense. It's total nonsense.
Dr. Victory.
That's me.
I've done 3 egg retrievals. My best one was my first one.
Okay.
Where I did not have letrozole included. I made 2 euploids that cycle.
Oh, nice.
In my following 2 ERs, I haven't made a euploid.
Okay.
And I wonder if I guess you just keep wondering. I guess you keep wondering, man.
That was terrible, man. You're like, that was a great hook. You kept everybody like waiting now, and now we don't know what to wait for.
Well, it's not my fault she didn't complete the sentence. I'm scrolling down here looking for the remainder of it.
Well, listen, I would go back to doing whatever worked for you before, although euploidy is really not related to anything anybody has been able to determine yet.
Not here. She really left us on a cliffhanger.
Disappeared.
Huh. Well, I tried. Don't say I didn't read that comment.
Yeah.
I read it and scrolled.
All right.
Hey, Dr. V.
Yeah.
We did this. Is there a certain, no, we did that. Hey, your majesties. Your majesties. That's good. Plural. See, you're included in this with me. You could join.
Yeah, I get to join.
Yeah, no problem.
Yeah.
I'm planning to do IVF.
Okay.
I will be 42 and 1 month.
Okay.
AMH 1.05.
Picomoles or nanograms? Keep going.
AFC 7.
Probably picomoles. Uh-huh.
Would you recommend fresh versus frozen transfer? We are only doing 1 more IVF cycle. My first IVF, I had 1 live birth from a frozen transfer.
Listen, if this is your only IVF cycle, it's arguable whether or not you should do PGT. And the reason I'm bringing up PGT is if you're doing PGT, you have to do frozen. I'm not a big believer in fresh IVF transfers. They don't make a lot of sense. The risks are higher. Well done frozen transfers do much better with getting results from a frozen. And so well done IVF transfers get a much better result from frozen. And so I'm not a big fan of doing fresh. And it allows you to do the PGT. And at 42, there's probably a pretty strong argument for doing the PGT. Having said that, if you only end up with 1 or 2 and you only make 7 eggs or 5 eggs or a low number, there isn't a really strong argument against doing a fresh transfer. I would probably want you to do PGT so that we're not wasting your time or your hopes putting in an abnormal embryo that has a very low chance of success, but it's not mandatory by any means. And so if you wanted to go fresh, you could go fresh. It's a lengthy discussion with your fertility specialist after you know how many embryos, like kind of the day before you're going to do an embryo transfer, so you know what to do.
Monarch T and Goat Dr. V. Here we go.
I'm good with goat.
Yeah, that's great. For your endo protocol, after 3 months of suppression, don't you have to do fully medicated because ovaries are quiet?
No.
I believe you do natural or modified. Can you please elaborate? And do you use trigger?
No, you do not, because if you just lift the suppression by waiting long enough, your body starts to respond again to that extra 5 days of letrozole and starts producing a lining. And sometimes you need a small amount of estrogen, but it'll respond. And if it doesn't, wait a month and then you will respond. With regards to trigger, I don't, because I find triggering just makes you have to chase the progesterone levels all over the place, and I hate chasing the progesterone levels. So it's easier to just start the progesterone when the patient's ready, but everybody's different.
Dr. V, we can hear you loud and clear,
Yeah.
but Tarek is a little bit quieter this time around.
Oh, that's because we'll come this way.
Gotta put my shoes back on.
We'll read a question and then move over while I'm answering.
Starting BMI was 48 kilos.
Whoa.
How much should total pregnancy weight be? Also, when I stop vag prog, which I do as a preventative measure, inspired by what you do for your patients, I'm 30 weeks. Thank you for all you do.
Okay, go through that again. That was convoluted.
Starting BMI was 48 kilos.
Okay.
How much should total pregnancy weight be? Question number one, I guess.
Close to 30 pounds because you're underweight.
Also, when to stop vag prog, which I do as a preventative measure, inspired about what you do for your patients.
We stop at 36 weeks.
I'm 30 weeks, and thank you for all you do.
Congratulations, and you're very welcome.
Hey, Dr. Victory. I'm supposed to be starting IVF with your clinic in January. The entire process has been emotionally stressful on my relationship.
Yeah.
What do you suggest for couples navigating this process? I already practice mindfulness, meditation, and attend weekly therapy.
Have sex all the time. Try yoga, meditation, prayer. Have more sex. Talk, communicate. That's the number one thing. You got to communicate all the time. Make sure you're communicating. Do things that you like together. You like taking a walk, take a walk. You want to walk the dog, walk the dog. You want to laugh at a Netflix show, laugh at a Netflix show. Go to the movies, go to the movies. Whatever you enjoy. The more you do that's kind of normalizing things, probably the better you're going to feel through the process. And you need coping mechanisms. So don't rely on some magical ability to just endure. It doesn't work that way. And guys get stressed through this process too. So it's important to have something in place to survive that.
Hello, doctors.
Yeah.
I always take that.
You love the doctors.
Yeah, there's nothing wrong with this one.
Yeah.
High risk pregnancy at 40 years old with first baby have GDM managed.
Okay.
And some elevated liver enzymes, not pre-E yet. My OBGYN wants to induce me at 37 weeks. Can I push it to 38 to avoid the C-section?
What? First of all, you don't need a C-section just because you're being induced at 37 versus 38. Elevated liver enzymes is very worrisome. We don't normally wait once you have elevated liver enzymes, so that doesn't make any sense to me at all. I would need way more details. And then the rest of it is just a matter of whether or not you are, stable. Are you stable? Are you not stable? How is everything going? So those things are really critical for you to know. Yeah. So I think ultimately it's a matter of how safe are you? If you're safe, great. If you're not safe, for God's sakes, don't do it. But that would be critical for you to understand.
Hi. What's funny is that no one can see all these funny things happening today.
I know.
Hopefully next week they can see us.
Yeah. I'm excited about the new mixer, but you are going to need a 4K mixer.
For sure. The way you're looking, absolutely. You know how I'm going to look?
Yeah, we need a 4K mixer.
Oh, this is funny. Hello. Is there anything I can do for my T-shaped uterus?
Oh my God. There's so much you can do. Come see us. We resect the notches and we make it a nice, happy shaped uterus, upside down piece of pie. And then you're corrected and you're normal. Often needs a balloon, needs pre-treatment and post-treatment with estrogen, but it's a very easy fix. I actually did one today. It takes about maybe 10 minutes. We have this phenomenal new Strauss hysteroscope that is amazing. If your hospital or your OBGYN doesn't have one, they're out to lunch. It's the best thing I've ever worked with. Crystal clear images, great camera, phenomenal cutting ability, very precise, great feel. It's an awesome instrument. Every surgeon's fantasy instrument.
Kings. Can't go wrong with that.
Not really, no.
Had a scan at VRC on stim day 7.
Okay.
24 lead that were letting go plus 4 follicles.
Yeah.
17, 12, 10, and 9.
Yeah.
E2, 4820.
Yeah.
LH, 7 PRG, 1 AMG, 16. Probably got those wrong for you.
Maybe, but that's
PRG, 1 AMG, 16.
okay.
Will retrieval be canceled, and how can we prevent lead follicle on CDD1 next time?
You can't really prevent a lead follicle that easily. People try different things: testosterone, DHEA, human growth hormone, estrogen priming. It doesn't always work. So some of those cases, we actually recommend just retrieving it and then leaving the other ones to grow. Sometimes you just sacrifice it. You go for the other ones. Losing one follicle so you can get 4 other ones is a worthy cause. That's okay.
Hello, sweet Dr. V and T.
Aw,
Also okay.
that's nice.
Yeah. I had no,
You're okay with that.
but the sweet's always good. Could my stage 4 endo and adeno be a big factor in low quality eggs? And can a lap surgery improve egg quality?
Yes and yes. So we know for sure that bad endo can impact your eggs. Adeno we don't know about, but endo definitely negatively impacts egg quality. Does lap surgery improve it? Yes, because we know that if you get rid of the endo, people get pregnant when they weren't before. So there's no question that the surgery can help.
All right, TikTokers, we're coming back.
TikTok.
Superstar T. That's the one I landed on.
Superstar
That's
T.
the one I landed on.
Wow, nice.
Yeah, it is nice.
I got goat.
You got go. Can't beat the greatest of all time.
I like goat.
Yeah,
That is good.
take it for
Yeah,
sure.
Yeah.
Is a hysteroscopy a standard part of lap? Would be nice to check everything.
So I'm not going to say it's a standard part because I don't want the host of surgeons who have done just laparoscopies to get in trouble, myself included. But we frequently do both. Now, if you've had a really well done saline infusion on a histogram and it showed no abnormalities, what's the likelihood we're going to pick something up on a hysteroscopy? Minimal, but there are times where we do. We'll go in there and look at the cavity and go, whoa, that doesn't look normal at all. So yeah, I mean, there are things you can do and ways you can fix things for sure.
Miscarriage of a euploid embryo after heartbeat. Reasons.
Oh, first of all, I'm sorry, that's terrible. Lupus, autoimmune diseases, microbiome problem, immune disorder, high sperm DNA fragmentation, thrombophilia, abnormal placenta. Those would be my top choices. I'm so sorry. That's horrible.
Dr. Victory.
Yeah.
This question starts off with hi.
Hi.
No
accolade.
Nothing.
No nothing.
Just hi.
I'm good with that.
That's all you're getting.
I don't need.
I need.
I know.
I know you don't need. I
don't need it, man.
Yeah.
I'm good. Yeah.
Yeah. Okay.
Let them do them.
Maybe I shouldn't read it. Maybe we should just walk away from this.
Rough.
That's rough.
Just ask.
All right. Hi.
Hi.
Difference between dual stim versus regular cycle. If you gain enough eggs the first cycle, do you need the second?
No. Enough is enough. How many eggs does a Frenchman need? Enough is enough. Terrible joke.
That's funny. That's not bad. I got it.
So
that's a francophone joke.
A francophone joke, yeah. So no, I mean, if you get enough eggs, you get enough eggs. Cancel the second one. We're really liberal about that. Like if you bought a 2-cycle package from us and you got enough on your first, we just give you back the difference. So don't worry about that. Or if you bought one and you need to, we just let you upgrade. So hopefully your other fertility clinic does that as well. But if you need to improve your egg number, yeah, sure, do a second cycle. If you don't, because you got 20 eggs the first time, why would you do another cycle? You probably have enough.
37-year-old pregnant with a negative PGTA tested embryo and maternity.
Maternity.
Maybe it's not spelled out that way, but is negative. Maternity is negative. Is that a thing?
It's a NIPT test.
Oh, I see. Maternity is negative.
Maternity.
Yes, it can be that.
Yeah.
Maternity
Yeah.
is negative.
Yeah.
Would you do an amnio?
Good God,
Good God.
no. That would be maniacal. Don't do that. If you've got a negative NIPT test, your chance of having a baby with a problem is less than 1 in 10,000. Why would you risk it with a chance of 1% or 0.5% that you miscarry the whole pregnancy after working so hard to get to it? Do not do that. Totally unnecessary.
CD11, Dr. V, of transfer cycle, lining only a 6. So they are waiting 8 days to check again. Normal?
8 days? No, that's way too long. And I would probably want to give you something to thicken your lining. So 8 days is a long time.
2 failed FETs and 1 FET ended in a miscarriage.
Oh.
What would you test or do next? All medicated cycles.
Well, I'd stop doing medicated cycles, highest risk of miscarriage, lowest chance of success. So that doesn't make any sense. And then I would do all the stuff I talked about earlier in the show. So check your partner's sperm, check for the DNA fragmentation, look at the shape of your uterus, look at your body mass index, your diet, your habits. Do you smoke? Do you drink? Do you use drugs? For both of you. Full hormone panel, full thyroid panel, full vitamin evaluation, and then the microbiome and the immune stuff that we do, thrombophilia screen, all of that. So there's a lot that goes into a recurrent implantation failure, recurrent pregnancy loss evaluation. And so we offer all of those to our patients. The patients don't always take all of them, but I'm going to offer them to you, and then you decide what's good for you.
How soon after a positive beta do you do an ultrasound?
2 to 3 weeks.
Any suggestions for the first IVF soon with high prolactin and PCOS, age 31?
Reduce your prolactin or you won't respond. And what was the other one? High prolactin and
PCOS.
Take metformin, be on inositol, optimize your weight. Do not go into an IVF cycle if you're super heavy. It has a very negative impact on your eggs. Optimize your weight first, get everything organized, take a GLP-1 before you go into it if you need it, if you're not in the thin PCOS category. Make sure your sugar control is excellent. There's a bunch of stuff.
Wonderful docs.
Oh, there you go.
This is nice.
Very nice.
Should I still suppress with Lupron after endo excision, or is it not needed?
We advocate for suppressing with Lupron and letrozole. You have to use both, not Lupron alone. After endo excision prior to fertility therapy, like an FET, because it's beneficial. But is it reasonable to skip it and go right into an FET? Depends on how many embryos you have, I guess. You will do better after suppression than you will just from surgery. Just like you do better from surgery and then suppression than you do from just suppression.
My lords, that's what it says.
That's going too far. I'm no one's lord.
How often do you see Asherman's post Mirena IUD, HSG and SHG negative?
Huh?
7.5 millimeter mid lining check.
That makes no sense at all. You would not have, because first of all, I've never seen Asherman's from an IUD like a Mirena IUD. It's a plastic IUD. It doesn't generate a negative response. So that's number one. Number two, many doctors actually use IUDs to prevent Asherman's. I've never done that because it made no sense to me, but whatever. They do it and they had no problems. Number three, if your lining is already 7 millimeters and your HSG and your SIS are negative, why do you think you have Asherman's syndrome? So that whole thing makes no sense to me. Somebody make it make sense, please.
A weird question.
Weird question. You know, I don't get asked enough. Like,
I actually don't even think the question is
like weird stuff now.
It's not weird at all.
I got challenged today. I didn't know the answer.
Really?
Yeah.
Hey.
There's a patient on Stephen Palter on his channel that asked me, which was weird, and him, if we knew how to deal with anti-centromere antibodies. And said, I need someone that's got a lot of experience. I was like, I've never even heard of this. So I don't know what.
You know what's amazing about that? I also never heard of it.
So I looked it up and I said, DM me. Now I know what to do.
Oh, here we go.
So there you go. Yeah. I need those, like.
This is a real easy one compared to that.
Question.
That one's this one's
or something I can scream about, like the ERA.
No, this is too easy. Do doctors care if one shave or not?
Do doctors care if somebody shaves or not? Oh God, I don't know if I can answer this and not get in trouble.
All right, then just.
I'm going to jump out of my doctor's shoes for a minute, right? So like, I'm not Dr. Victory. I'm just Rahi Victory for a minute. Yeah, absolutely. It is very nice when patients are hygienic. I'll leave it at that. And there is a certain element of cleanliness and attention to detail. And when it's easier for us to be able to see what we're doing than when we have to fight the elements to do what we need to do. So yes, doctors care. For sure, doctors care. I care. I'm a mammal that cares.
Are you from Windsor?
Originally, no. I'm originally from Iran. I grew up in North York almost all of my life. And then I went to the States, and then Kingston, and then London, and then Windsor.
Hey, 3 weeks post successful transfer. See what happens when you allow for
I like
high?
A little hay, though.
A little hay?
I think it's fun. Keep it real.
I'm keeping it real. I like my Dr. Majesty. This is me keeping it real. I like this.
That's your real.
That is my
Let
real.
them have their real.
This is their real as well.
Yeah, like they deserve their real.
Yeah, I guess everybody's got a reel here. Now I even lost my spot because I was scrolling all over the place.
3 weeks post transfer.
Yeah. Hey, that's the way I found it.
There you go.
3 weeks post successful transfer.
Yeah.
Is burning sensation, cramping, and brown discharge normal?
No. Go get checked out. Get your betas followed serially, please. And be careful, because that's the kind of thing where we worry about ectopics and stuff.
Hello.
Hello.
See what we did? We opened the door now.
Hello. My name is Inigo Montoya.
There you go. If your ferritin level is low,
ferritin.
What should it be before an FET?
In our Canadian units, 100.
Hello. I'm getting ready to have baby number 2.
Awesome.
IUI.
Okay.
Uterine polyp that wasn't there 1 month prior.
Okay.
Will polyp shed the cycle?
Will polyp shed the cycle? Yes.
Shed with cycle. Will polyp shed with cycle?
Oh, shed with cycle? Not usually. It depends on how big a polyp it is. The polyps tend to have like a pretty big base. So you typically will need a hysteroscopy or a DNC to get rid of the polyp.
Hi. 5 failed transfers.
Whoa.
What should I do now?
Contact Dr. Victory at Victory Reproductive Care, and I will fix it so that you don't fail any more transfers. Who fails 5 transfers? That's insane. Who's doing that to you without figuring out what's wrong? I can't stand stuff like that. It drives me crazy. Why are people being put through 5 failed transfers? Just try again. Did they change something? Did they reevaluate something? Did they look at what was wrong? Did they check your microbiome? Did they offer you microbiome testing or immune testing? Did they relocate the shape of your uterus? Like, no one should just be going back for 5 embryo transfers. There's great data from Richard Scott's group, and I've talked about this before, showing that 5 euploid embryo transfers with no extra treatments, tests, anything, gets you a 98% chance of having 1 live birth. Okay, I love that. I think that's freaking awesome. Hallelujah. Great hope for a lot of people. Do you know how many cycles of IVF most people need to do to get 5 euploid embryos? That is not an easy number to achieve. And if you're 38 or 37 or 40, it's like almost impossible. You're just spending dollar after dollar after thousands of dollars, after tens of thousands of dollars, without getting the benefit of an in-depth evaluation that you deserve. That should be mandatory. It should be morally mandatory that people pay attention to the details and figure out what's wrong. You cannot let someone just keep telling you transfer again, transfer again. That's unacceptable. To me, that's unethical. I don't get it. It makes no sense. just my opinion. It's not a guideline or a enforceable statement, but it is for me morally. I answer to God. I'm not going to let people just keep throwing their money away. That's insane. It drives me crazy. You know, at a recent conference, there was a discussion in regards to the Fortune IVF app. And the Fortune IVF app can literally predict if you're going to have any chance of success at all before you start your IVF cycle. So you're just sitting there at home, you've spent time with the doctor, he's giving you all the information, you write down a bunch of numbers, you go to the Fortune IVF app. I've got it. My phone is currently TikToking, but you can plug in some numbers and it'll literally spit out the answer for you and tell you what's wrong. Okay. Like, do you have a chance? Do you not have a chance? How high is your chance? Are you in the good, bad, or ugly category, whatever they're called, right? Very bad, bad, fair, good, very good, something like that, right? So if you're in that very bad category, you have like a 0% chance of success, 0. And you can figure that out before you invest the time and the money. So I'm in this panel and the discussion came up and people that were involved in the panel were like, well, you know, that's just one AI tool, because they don't want to lose the chance to support patients. Don't do that. That's insane. Like, patients deserve to have answers. Patients deserve to know about everything as early as possible. Does that mean we're going to lose money? You're damn right it does. We're going to lose money. We're not going to make as much, because it means some patients shouldn't start. But those patients deserve to know they shouldn't start, right? Like, I'm not going to sleep at night saying, oh, wow, I made an extra, $20 or $1,000 or $10,000, but I screwed someone over. How are you going to sleep? That's like just an epically immoral thing to do. It's unethical in the extreme. It's even more unethical when it's coming from us, right? You get some sleazy Instagram influencer or whatever, these crazies on my vitamin K post who are selling Reiki. Okay, great. Have at it. There is no morals there. It's all unethical. But when it's coming from an actual doctor and you're not sharing the truth with patients, that's not okay. Not on any level in any field of medicine.
I think they just don't like the absoluteness of 0. I think they want to make it a 1. You know what I mean?
Like a 1%.
A 1%. They don't. It's too definite for them.
It's actually 0.
I know it's actually 0.
It's 0. Like in their study for Fortune IVF, 0. Nobody had that. When you were in the very bad category, there was no chance of developing a euploid embryo. Nobody developed a euploid embryo.
It is what it is.
It is what it is, right?
Yeah.
What time is it?
It is 9:03, sir.
I was gonna say it feels like it. I don't have a watch, but it
is 9:03. No, you ended it on a good note.
Yeah. All right. Anything left? Any important questions? Burning questions to answer?
Burning?
Yeah.
Burning. Thank you is what they're saying.
Okay, don't forget, huge shout out to Matt V, Mattine V on Instagram. Please inundate him with calls and texts and anything else, and lots of love, and wish him a happy birthday. I'm very proud of you, son. I love you, son. And to my other 2 rascals, I love you too. Nessim, thank you for working so hard. And Jenna, thank you for coming to Brussels to see your dad this weekend. I love you, honey. Have a great night, everybody. Next week, we have a very special show. We have Dr. Stephen Poulter on with us for a podcast first, and then he's staying on the live, and he and I will go head to head on some questions on how to manage fertility stuff. And Stephen's a great guy and very bright and has probably the world's most successful fertility TikTok, Instagram, YouTube. He's huge. So we were just talking for about an hour on Thursday before I left for Brussels, and we're going to have him on the show. So very excited about that. And we're going to talk about one of his very, very phenomenal programs that he was explaining to me, all about PCOS. He's doing something nobody else is doing, and it sounds very, very cool. So if you're a PCOS patient, let us know, because you want to be on that show. Have a great night, everybody. I'm in the OR tomorrow. Maybe I'll make some videos. Stay tuned for more. Take care. Have a good night.